Ako po, Sir Patrick.
Okay, okay. Sige. Start ka na. Thank you.
Cor pulmonale. Dito sa cor pulmonale, ito dalawang organs, yung heart natin tsaka yung lungs. Cor pulmonale or right-sided heart failure is an enlargement of the right ventricular due to high blood pressure in the lungs, usually caused by chronic lung disease. Dito, kaya yung right ventricle lang tinatamaan natin kasi gawa nung, di ba sa heart natin may dalawa siyang the pulmonary circulation tsaka systemic. Yung sa right-sided ng heart natin, doon yung tinatawag ng pulmonary circulation. Yung right ventricle natin nagpapadala ng blood papunta sa lungs natin. Kaya ang nangyayari, nagkakaproblema yung lungs tapos mas naapektuhan yung sa puso. Kaya sa right ventricle yun. Definition: the cor pulmonale is a condition in which the right ventricle enlarge with or without right HF as a result of disease that affect the structure or function of the lung or its vasculature. Etiology: mid-19th century from Latin pulmonary artery hypertension. Ito yung risk factors niya. Predisposing: COPD, pulmonary embolism, age, sex, heredity, precipitating lifestyle, diet, perpetuating deprived resources. Sign and symptoms: wheezing, fatigue, cough, increased shortness of breath, increasing of edema of the feet and legs. Ito naman po yung mga diagnostic niya. CT scan, echocardiogram, chest x-ray, lung scan, medical management, diuretics, calcium channel blockers, vasodilator drugs, theophylline, warfarin. Assessment: difficulty of breathing, abnormal breath sound. Diagnosis: impaired gas exchange related to excess fluid volume in lungs. Increased pulmonary vascular resistance, ineffective airway clearance as evidenced by dyspnea. Planning: health teaching. The client will demonstrate particular breathing pattern, adequate fluid volume, and electrolyte balance. Improve airway clearance and restore breathing pattern. Imbalanced nutrition, less than the body requirements. Related to breathlessness as evidenced by weight loss. Parang sa diagnosis yun. Pero nandito. Assess intervention. Assess the monitor respiration and breath sounds, noting rate and sound. Demonstrate effective cupping and deep breathing techniques. Increase fluid intake per day within cardiac tolerance. Evaluation. Patient response to intervention. Teaching and action performed. Airway clearance and fluid intake of the patient has improved. Attain the progress towards the desired outcome. Kasi ito na po yung pathophysiology na po nagsisimula sa predisposing factors, age, sex, male, female, heredity, etiology, pulmonary, precipitating factors, lifestyle, diet. Dito po tayo sa may hypoxia. Ang nangyayari po kasi kapag sa or pulmonale, kapag naapektuhan po yung lungs natin, kunyari po na pressure po, naapektuhan po yung alveolar, which is kapag naapektuhan po yun, nagkakaroon po ng hyponic pulmonary arterial vasoconstriction. Nagko-constrict para hindi na po siya mapapasukan ng blood. Tapos po, dahil marami po yung tinamaan, marami po yung nagkaganon, tapos kaya po nagkakaroon ng decrease in pulmonary vascular. At dahil nagkaroon po ng constriction, siyempre po kapag nagkaroon ng constriction, mas tataas po yung pressure. At kapag tumaas po yung pressure, magkakaroon tayo ng increased resistance in pulmonary circulating system. Tapos doon na pumapasok yung pulmonary hypertension, yung may resistance na sa may lungs. Sa pulmonary hypertension, doon na rin pumapasok yung shortness of breath, yung abnormal breath sound, yung wheezing, ano pa ba isa? Yung wheezing, tsaka yung cough. Doon na sila napasok sa pulmonary hypertension kasi nandun yung problema. Tapos yung increased right ventricular afterload equal to loud second heart sound. Tapos right ventricular hypertrophy. Ang nangyayari kasi, di ba may resistance? Yung heart natin, mas nagpapump siya. Ibig sabihin, kapag mas nagpapump, yung muscles mas na-enlarge. At kapag mas na-enlarge yung muscle natin sa puso, yung volume na dapat papasok doon is umuunti na dugo. Ang nangyayari, mas maraming muscle. So, mas malakas yung contract. Pero yung fluid na pumapasok doon, mas lumiliit. Kasi mas malaki yung muscle, na yung enlarged heart muscle. Tapos dito na papasok yung right ventricular failure. Una is further impairment of blood circulation. Dito naman is yung pumapasok yung fatigue. Kasi syempre, kulang sa oxygen yung ibang mga tissue sa katawan natin, mga organs. Tapos sa increased capillary hydrostatic pressure throughout the venous system, dito na pumapasok yung edema kasi nahihirap pa ng bumalik. Babalik ko sa may puso natin, gawa nung kulang na nga yung volume sa puso natin dahil mas malaki na yung muscle. Tapos increased venous pressure. Ayun lang po. Ito na question. Lab results indicate that the client's serum aminophylline level is 17 mcg/ml. The nurse recognized that the aminophylline level is A. Within the therapeutic range. B. Too high and should be reported. C. Questionable and should be repeated. D. Too low to be therapeutic. Ano pong sagot niyo?
What's your answer? The question is, lab results indicate that the client's serum aminophylline level is 17 mcg per ml. The nurse recognized that the aminophylline level is A. Within therapeutic range, B. Too high and should be reported, C. Questionable and should be repeated, D. Too low to be therapeutic. Okay. So sa ganitong question, di ba? Remember before, I have told you, when you have a question, you're confronted with a question and you're not sure, or should I say, hindi nyo alam yung idea on how, okay, on how you are going to get the correct answer, okay? What you are to do is first identify kung meron kayong same wavelength of the answer but different modifiable, okay? So first here, ang makikita nyo, among the four, there are two. Merong too high, merong too low. Okay? So, ang binabanggit dito, they are both different. Okay? But, they both the same wavelength, too high, too low, kasi they are opposing, di ba? The problem here is that kapag may too high ka, it should be reported. But, if you have too low, wala kang binabanggit if this would be reported. So, kung makikita mo, hindi sila yung, they are not the answers of the same wavelength. So, isa lang sa kanila ang dapat mahanapan ninyo. Okay? Alin ang mas makikita natin katulad? High and should be reported. Meron ka bang may nakikita dyan na should be reported? Wala. Meron dito, should be repeated. Merong therapeutic, meron din therapeutic. So therefore, you need to eliminate now the too high and should be reported. And should be repeated. Kasi wala naman sila magka-wavelength. So eliminate this one, eliminate this one. Now you only have within therapeutic range and too low to be therapeutic. Pwedeng ang sagot dito is too low kasi nga, in-eliminate mo na yung too high. Tama? But remember here, you didn't eliminate the too high because they have the same wavelength. You eliminated too high because they have different modifiable factors. So dito, modifiable factors na should be reported. Pero in here, wala kang modifiable factors. So therefore, kung walang modifiable factors dito, eto na ang tamang sagot within the therapeutic range. Okay? I am not asking you to have a correct answer. I am asking you to learn the art of elimination. Because the moment you learn how's the elimination, you'll get a more chance of passing the board exam. Why we're doing this practice, basically hindi naman natin dapat itong ginagawa sa MS. However, I have a very limited time and a very limited space and opportunity na ituro sa inyo yung kabuuan ng konsepto ng MS. And taken for a fact na dalawang nursing practice exam ninyo sa board exam, lahat yung MS. At kahit yung nurse practice 1 ninyo and nurse practice 2 ninyo, though it's community and community and primary nursing, lahat pa rin yun may element ng MS. So you need to master how to take the board exam question, okay? Alisin niyo sa sarili niyo na when a question is being posted, you try to look in the Google what's the correct answer. Alisin niyo yan. Because you will be fooling yourself that you can get the correct answer. But in the final exam, you wouldn't be able to do that. So practice how you eliminate, analyze how you choose an option, and then later on you can assess whether you are already capable of choosing the correct answer. Anyways, it's multiple choice lang naman sa board exam. I don't know kung gawin nila katulad sa NCLEX type na select all that apply. Okay? Next question.
Core pulmonale affect what part of the heart? A. Left ventricle. B. Right ventricle. C. Posterior ventricle. D. Anterior ventricle. Ano classmate sagot nyo? B.
Okay. So the correct answer is, natin pahirapan, it's B. Do you have posterior ventricle and anterior ventricle? Do we have? Meron ba tayong posterior ventricle and anterior ventricle?
Wala po.
Sure? We have. We have posterior and anterior ventricle. Sasaktan ko kayo. Your brain has ventricles. Okay. But, since ang pinag-uusapan natin dito, core pulmonale, we all know for a fact na hindi siya brain. So, kung hindi siya brain, let's eliminate the posterior and anterior ventricle. So, what remains is the left and right ventricle. Kung hindi natin alam ang core, hindi natin alam ang buong detalye ng core pulmonale, that's the reason why lagi ko rin binabanggit sa mga nursing student. Lagi kong binabanggit to sa mga nurses, hindi pala sa nursing students. The one way of being familiar with certain diagnosis or certain signs and symptoms is for the nurses to have a short background of Latin and Greek word. Okay? So pag binanggit natin dito, core, pulmonale, we know cora, di ba? Cora means your heart, and pulmonale means your lungs. Tama? Now, if this is core, pulmonale, unang binanggit ay heart to the pulmonary. Pero basically, kapag pinag-aralan mo to, it's the lung that causes all the problem, which affects the heart. Pero pag binanggit mo, core pulmonale, meaning it's the heart to the lungs. So kapag itong itself palang titignan mo, ano ba ang nagsisimula? Anong part ng heart ang papunta sa lung? Is it the left or the right? We all know for a fact that it is the right ventricle through what? Through your pulmonic semilunar valve to the pulmonary arteries that is to your lung. So the correct answer is right ventricle. So that's how you are going to select the correct answer. So you should have a little background of the Greek and Latin words. So para po nakita nyo, okay. So it's affectation of right to the lungs. And pwede naman din baliktad. Okay? Pero kaya lang pagkakasunod niya is core pulmonale. So therefore, it's from the heart to the lungs. Okay? Question number 2.
What is the primary cause of core pulmonale? A. Pulmonary hypertension. B. Vitamin B12 deficiency. C. Diabetes. D. Cyanosis. A. Sagot.
Okay. So kung pinakinggan nyo naman siya kanina, okay, what is the primary cause of cor pulmonale? You'll get the correct answer. You'll only have three choices dyan. Cyanosis, it's not a cause, rather it is a presentation. Diba? So we all know for a fact that cyanosis has a cascading factor pa before it leads to cyanosis. So eliminated again cyanosis. So you choose among the three na lang. So vitamin B12 deficiency, okay, we do not know much about vitamin B12 deficiency that could affect your heart. Instead, we know B12 has something to do with your blood and your stomach, I believe. Okay? Hindi ko sure yung stomach. So, you have an option na lang A or C. Pero since cor pulmonale, among the two, diabetes or pulmonary, medyo related na yung pulmonary sa pulmonale. So you choose pulmonary hypertension. So the correct answer is A. Nanonote nyo ba kung paano pumili ng sagot? Masterin nyo kung paano, eto yung bagay na hindi ko natutunan when I was nung college ako at hanggang sa mag-board exam ako. So this is one thing you need to master. Okay? On how, kasi kahit gaano kahirap yung, walang mahirap na tanong sa magaling mag-eliminate ng maling sagot. Okay? Okay, next.
Si ano na po, si Mr. Pato Physiology namin.
Okay, Mr. Pato.
Pato.
Pasok. Sige.
Magandang hapon po, sir. At sa inyo. Okay. Report ko ay CAD or Acute Coronary Syndrome. And myocardial infarction. Ano ba pinagkaiba ni ACD at ni myocardial infarction? Sabi dito, si ACD ay rene-range niya lang yung condition. Kumbaga, rene-range niya lang yung condition yung blood flow natin. Kumbaga, rene-reduce niya yung blood flow papunta sa heart. Yun po yun. Tapos naman, si MI or si myocardial, ginagawa niya, si blood flow, dinidecrease niya papunta sa heart. Kaya yung mga cells natin, pinapatay niya, kaya nagkakaresulta, nasisira, o yan, na-destroyed. Kaya yung dinedestroy niya yung heart tissue or yung heart muscle. Next po. Yun yun, yung definition niya. Tapos naman, meron tayong 3 types ng ACD or MI. Kumbaga, tawagin na, yung una muna, unstable angina. Ano ba yung unstable angina? Sinasabi niya unstable angina, habang partial rupture of an artery. Kumbaga, si blood vessels, dadaan kay artery, kapag may nabutas doon, yun nga, imbis na yung daluyan lang itama, may pumutok. Pero sinasabi dito, does not cause permanent damage to the heart. Tapos naman, si sunod naman, si ST segment elevation, sinasabi lang dito, heart attack siya, pero cause siya ng extensive heart damage. Sunod naman, si non-segment elevation, myocardial infarction. Ini-intermediate lang yung form of ACS, cause less extensive damage to the heart. Yun po. Next po. Geology. Ano ba pinagkaiba ng CHD at kay atherosclerosis? Si CHD ay si coronary heart disease. Sinasabi dito, is the narrowing or binablock niya yung blood vessels sa artery, usually caused by atherosclerosis. Yun po yun. Tapos atherosclerosis naman is the build-up of the cholesterol and fatty. Kumbaga, kapag tayo nagdadigest ng food, yun nga, kumbaga, yung mga carbohydrates natin, doon namumuo. Kaya tinatawag siya na plaque. Ito to. Nagkakaresulta siya ng plaque. Next po. Risk factors nga, predisposing family history, male sex, yun nga. Kaya nga, sa lalaki kasi kadalasan talaga yon nangyayari yung ganitong cause ng disease sa heart. Ethnicity, yung age, tapos naman sa precipitating, siyempre physical inactivity dahil nga hindi na na-activate yung katawan natin, yun nga nangyayari. Tapos high blood cholesterol, tapos mayroon pang cigarette smoke, yun nga, lalong nangyayari yung heart natin, lalo na dadamage. Tapos obesity pa, tapos overweight pa, tapos hypertension, diabetes, and hyperlipidemia. And then, sunod is perpetuating. Dahil nga, poor natural practices. Dahil nga, hirap siya sa, ibig sabihin, nakasanayan niya kumain ng masarap, hirap siya mag-prepare ng gantong masustansyang pagkain. Ayun po. Next. Sign and symptoms. Sinasabi sign and symptoms, dahil nga si chest pain nga, yung sa angina, discomfort, ayun nga, madalas nangyayari to sa atin. Tapos nagkaka-pressure, tightness, burning pain, spreading from angina, shoulders, arms, abdomen, back, neck, or jaw. Nausea, vomiting, indigestion, yun nga, shortness of breath or dyspnea, sudden heavy sweating, lightheadedness, dizziness, or fainting, unusual or unexplained fatigue, and feeling restless or apprehensive. Next po. Diagnostic. Ba't ito ba ina-order ng doktor? Ba't niya ba ginagawa to? Para kaya ini-ECG natin para makita natin ano ba yung problem. Pag ini-ECG yung heart, para makita ng doktor ano yung tama sa heart. Para makita niya ano ba yung makita niya. Tapos naman, sa FBC o kaya yung tawagin ay chine-check dito yung numbers of cells, yung blood natin, yung RBC, WBC, at yung platelets sa FBC. Sa glucose lipid profile, ba't na chine-check ng doktor para ma-measure natin yung risk niya. Kumbaga, basta yun po. Next naman, yung cardiac enzymes, ba't nga inaano nito, dinadiagnose, para ma-measure din uli natin yung blood levels of the enzyme. Tapos yung chest x-ray yun po. Next po. Ayun nga. Ito yung medical management niya sa initial o tawagin MON. Morphine. Para saan ba si morphine? Ayan, ito yung binibigay ni Doc. Si morphine daw, tinitreat niya daw yung severe pain. Ayun nga, dahil nga si severe pain, dahil nga sa heart, para ma-treat niya. Kumbaga, pababain yung pain ng heart. Yung vein, paso yung muscle. Yun. Next. At yung oxygen, tapos yung aspirin, si aspirin at probion, tinitreat naman niya yung blood clots. Dahil nga kaya yung blood vessels natin, imbis na yung blood vessels ay maganda daluyan, yun nga, nagkaka-blood clot. Kaya ginagawa ng aspirin, ni-treat niya para yung blood vessels natin gumanda yung daloy. Tapos naman si nitrates, kaya binibigyan ni Doc, patient, dahil para magka-dilate. Kumbaga, lumaki yung daloy ng blood vessels. Dinadilate niya, lumalaki. Para ma-improve natin yung blood vessels. Yun po. Para yung blood vessels, oxygen. Yun po. Next po. Medical management, ayun nga. Ba't inaano ni doktor? Ganyan. Ito yung mga medical management ni doktor sa patient. Depending on your diagnosis, medication for emergency or ongoing care. may include the following: thrombolytics, nitroglycerin, antiplatelet drugs, beta blockers, wait lang, para, at si ACE inhibitors, si angiotensin receptor blockers, at si statin. Yun po. Next po, Patrick. Ayan na, sa atin. Medical management. Ayun nga sinasabi ni Doc para maiwasan natin yung heart disease. Ayun nga, pagtigil ng smoke, quit smoking para hindi magka-iris yung heart natin, eating healthy. Yung sinasabi ni Doc, yung eating healthy para kumain tayo ng masustasyang mga pagkain, tulad ng isda, gulay, ganun, prutas, para yung heart natin, maganda yung daloy ng blood vessels. Para yung pump niya, maganda. Tapos reduce alcohol intake. Kapag tayo nagiinom ng alak, lalong ma-epekto yung heart natin. Yun po. Tapos exercise training, yun nga. Yung sabi ng Doc, kailangan natin mag-exercise para simpleng exercise, jogging, para yung heart natin, maganda yung daloy. Ganun. Tapos healthy eating habit, yun nga. Kailangan yung kain natin, wag masyadong, kumbaga, wag tayo dun laging mahabit na. Sa isang ganun. Next po. Surgery. Si Angie, yung ginagawa din si Angie surgery, ginagawa ni Doc dito, pag may complication sa heart, pinapasukan siya ng catheter tube, gano'n. Tapos lalagay i-inflate ng hangin, magkakabalon para yung blood vessels natin para gumanda yung daloy. Yun po. Tapos coronary bypass surgery, sinasabi dito, procedural surgeon takes a piece of blood vessels, graft, kung tawagin, from another part of your body and creates new route for blood and that goes around bypasses or block coronary artery. Yun po, ibig sabihin. Nursing management. And sa atin to. One of the most important aspects, ayun nga, pag tayo mag-a-assist tayo sa patient, pag sinabi ng doktor, ayun ang assist natin. Tatanong natin patient kung mayroon ba siyang chest pain or not relieved by rest or medication. Kung nag-take siya ng ibang medic. Tapos monitor natin yung vital signs niya, especially syempre yung blood pressure. At yung pulse rate, dahil yung pulse rate relate sa heart. Tapos assist natin yung shortness of breath, kung mayroon ba siyang dyspnea, takip niya, and crackles. Tapos assist natin yung nausea and vomiting. Tapos assist natin yung decreased urinary output niya. Tapos assist din natin yung history illness niya. Tapos perform natin yung precise and complete physical assessment to detect complication niya, yung changes in the patient status, assess IV sites and frequently. Next po. Based on nursing diagnosis niya. Based on the clinical manifestation, ito yung mga diagnosis, ito yung nursing diagnosis natin. Ineffective cardiac tissue perfusion related to reduced coronary blood flow. Sunod is risk for ineffective peripheral tissue perfusion related to decreased cardiac output from left ventricular dysfunction. Doon na-epektuhan yung heart natin. Tapos deficient knowledge or related to post-MI self-care. Next po. And ito pa yung diagnosis ulit natin. Ineffective cardiac tissue perfusion related to reduced coronary blood flow. Risk for ineffective peripheral tissue perfusion related to decreased cardiac output from left ventricular dysfunction. And deficient knowledge related to post-MI self-care. Ayun, plano natin. Siyempre, ito yung plano natin. Absence of respiratory dysfunction, maintenance of a treatment of adequate tissue perfusion, reduce anxiety, absence of early detection of complication, chest pain, absent and control, heart rate rhythm sufficient to sustain adequate cardiac output, tissue perfusion, achievement of activity levels sufficient for basic self-care, Anxiety, reduce manage disease process and treatment plan and prognosis under SUS. Next po. Intervention. Ayan. I-administer natin yung oxygen along with the medication therapy to assist with relief of symptoms. I-encourage natin yung bed rest with the back rest, elevate to the healthy para ma-decrease stress, discomfort, and dyspnea. Encourage changing of position frequently to help keep fluid from pooling in the bases of the lungs. Check skin, temperature, and peripheral pulse frequently to monitor tissue perfusion. And magpo-provide tayo information in an honest and supportive manner. Monitor the patient closely for changes in cardiac rate and rhythm, heart sounds, blood pressure, chest pain, respiratory, urinary output, changes in skin color, and laboratory values. Evaluation. After implementation of an intervention within the time specified, the nurse should check if there is absence of pain or ischemic signs and symptoms, myocardial damage is prevented, and absence of respiratory dysfunction, and adequate tissue perfusion maintained, and anxiety is reduced. Yan po. Okay, sa pathophysiology, nasabi dito, dahil nga may ACD, ginagawa ng ACD, ito yung factors niya. Aging, play cells, family history, ito yung ACD. Ginagawa ni ACD, binibuild up niya yung sclerotic plaque in the coronary artery. Kaya nga nagkaka-atherosclerosis. Ginagawa ni atherosclerosis, reduction of blood flow to the area to the, kaya nagkaka-cardiomyositis. Kaya nagkaka-reduction of the blood flow, nagkaka-poor oxygen supply. Kaya nagkaka-ischemia. Dahil nga nagkaka-poor oxygen supply, yun nga, nagpa-plaque, fracture sa thrombosis. But vessel is not totally included. And hemodiphedal risk factors niya, yung hypertension, dyslipidemia, poor diet, diabetes, sedentary lifestyles. Yun nga. Dahil nga poor oxygen supply tayo, dahil nga plaque rupture thrombosis, meron siyang two types, yung myocardial infarction, yung non-STEMI, at yung isa, total occlusion of the blood vessels of the artery, or yung STEMI segment. Nagawa ni myocardial infarction, yung nagkaka-acute coronary syndrome. Ulit, teka. Yun nga, dahil nga nagkaka-poor oxygen supply, yun nga, nagkaka-chest pain, kaya nagkaka-acute coronary syndrome. Dahil nga si chest pain, tinitreat niya yung morphine, oxygen therapy, yun nga, yung nasabi ko kanina. Tapos, dahil nga na-treat nga, ongoing modification, yun nga, with smoking, healthy eating habit, reduce alcohol intake, and exercise training. Dahil nga na ongoing to, yun nga, pharmacological therapy, yung nangyayari, yung kanyang benefits, yun nga, beta blocker, argogenesis receptor, aspirin, and statins. Dahil nga nagkaka-acute coronary syndrome, yun nga po, pumapasok yung chest pain, yun nga po, sa angina, at pabanga. Kaya taas uli. Taas uli para, yan. Yun nga, marami siyang symptoms, si chest pain, tightness around chest, rigid to jaw, sa left arm, diaphoresis, feeling of impending doom, gusto yung vomit. Yun nga, dito nga, yun nga yung sa diagnosis, ECG, FBC, glucose lipid profile, and cardiac enzyme. Pababa.
Finish na? Hello?
Okay. Si non-STEMI, dahil si non-STEMI, ginagawa ng non-STEMI, ini-intermediate niya yung form of ACS cause less extensive damage to the heart. Ayun nga, damage to the heart, sub-endocardial infarction, yun nga, nagkaka-low risk, cardiac enzymes, and ECG. Gagawa ng low risk, high risk naman yung antiplatelets, anticoagulant therapy, beta blockers, revascularization, angioplasty, and stenting. Dahil sa STEMI naman, ginagawa ni STEMI na heart attack, kaya nagkaka-transmural infarction. Yun nga, dahil nga nagkaka-transmural, nagkaka-rupture, damage sa papillary muscles, yun, kaya nagkaka-increase troponin, CKMB. Yun nga, kaya dahil nagka-rupture damage, yun nga, pupunta sa emergency perfusion. Yung first choice is primary percutaneous coronary intervention balloon, yun nga, na stent, and second choice is fibrinolytic therapy. Yun lang po. Para next. Question. IV heparin therapy is ordered for a client. While implementing this order, a nurse ensure that which of the following medication is available on the nursing unit. Ano sagot, Eden?
Okay, so the question is, IV heparin therapy is ordered for a client while implementing this order. While implementing this order, a nurse ensures that which of the following medications is available on the nursing unit. So basically, kapag may gantong klase ka ng tanong, okay, IV heparin, you should know what's the purpose of IV heparin. So balik sa pharmacology. Pag tinatanong ka ngayon kung ano dapat yung gamot na meron ka available when you're giving a certain medication, in this case, IV heparin, hinihingi niya anong antidote ng IV heparin. So you choose vitamin K, aminocaproic acid, potassium chloride, or protamine sulfate. Now, we all know for a fact na yung potassium chloride, parang hindi naman. Kasi parang ang kalaban naman niya, sodium. So, dapat eliminate na natin siya. So, eliminate the potassium. So, you have choices na tatlo na lang. Aminocaproic acid, protamine sulfate, and vitamin K. Now, among the three, ano yung medyo hindi kayo sure na gamot? Vitamin K, aminocaproic acid, or protamine sulfate? We all know for a fact na vitamin K somehow has something to do with blood. Di ba? Aminocaproic acid, chances are amino, something to do with protein. So, eliminate na natin. Protamine sulfate is something we do not much know. Tama ba? Tama ba? Now, wait, binabasa ko yung messages. Now, you have two options na lang. It's either vitamin K or protamine sulfate. What is the correct answer? Anyone? Okay. Um, this is actually the correct answer would be D, protamine sulfate. Okay? Tama naman din na yung, sir, bakit ganon? Vitamin K, nagka-clot yan eh, di ba? So, dapat siyang opposite ng heparin. However, yung vitamin K natin is an antidote of a certain anticoagulant. And that is what? What? Vitamin K is antidote of what? Antidote for what? We all know for a fact na common na to, wag niyong kakalimutan ha. Vitamin K is an antidote for warfarin. Warfarin. Okay? VW, medyo magkalapit, VAW, warfarin ang vitamin K. So therefore, it cannot be an antidote for heparin. Okay? Although both warfarin and heparin are anticoagulant, okay? The specific antidote of warfarin is vitamin K. So among the two, vitamin K and protamine sulfate is the correct answer as antidote for heparin. Okay? So, strengthen also your pharmacology kasi it would help. Okay? May next reporter pa? Wala na. Okay, there's none. Okay. So, balikan lang natin yung mga previous reports ninyo. To answer some sort of questions.
Okay.
Do you have questions pala regarding these reports? Yung ACD, CAS, CAD and ACS pala, and the core pulmonale. Do you have questions? Questions, do you have? Wala. Pagod ba kayo? Parang pagod kayong lahat. What happened?
Hindi naman po, sir.
Okay, hindi. Sige. Ba't nga ba ako nag-share? Okay. So, let's discuss the previous reports. Okay? Naririnig din naman ako So, let's talk about first asthma. Okay? Who reported asthma, by the way? It was reported by Reyes, di ba? Okay. So, asthma. So, we all know for a fact that asthma, it is a chronic inflammatory disease. Okay? So, pag sinabi natin chronic inflammatory disease, ibig sabihin, malala. Okay? Malala siya. But not necessarily, pag chronic, ibig sabihin, matagal na siya. Okay? But most often than not, pag sinabi natin chronic, mas madalas, matagal na siya. Matagal na siya nangyayari, nagre-recessive lang, ibig sabihin, nagiging dormant stage, hindi siya nagiging ganun ka-active. However, when it becomes active, it is chronic or malala. Okay? So, inflammatory disease of the airway, so ibig sabihin na pinag-uusapan natin dito, daluyan ng hangin. So, we all know for a fact na kapag meron tayong problema sa daluyan ng hangin, then therefore, may problema na tayo sa gas exchange. So, our problem would focus on the oxygenation of our client or of our patient. So, usually, ang asthma natin, meron siyang tatlong hallmark sign. So, meron siyang hyperresponsiveness, and meron siyang mucosal edema and mucus production. But among the three, okay, ang pinaka common sa kanya is of course yung mucus production. Okay? No. Your bronchoconstriction or hyperresponsiveness. So that's asthma. Okay? Now, Yung asthma, basically, wala talaga siyang causative agent. Okay? But what is being pinpointed as the reason for asthma, of course, the allergens. Because asthma is usually an allergic response. And basically, that's allergens. Okay? So, na-note naman ni Ms. Reyes that there are a lot of factors to include sa asthma. Of course, the allergy, kaya nga may allergen. The family history, okay? Madalas na hindi kapag yung parents mo merong asthma, likely one of you sa magkakapatid magkakaroon ng asthma. Though, by research or by science, wala pang proven link na it is genetic. Okay? Of course, if you are smoking, okay, you are prone to have asthma for the reason that your cells in the airways are receiving nicotine. Okay? Nicotine that is not and should not be naturally absorbed by the cells of your lung or of your airways. Precipitating, of course, the environment. If your environment is medyo mausok, marumi, if your environment is nakapalibot ng mga nag-i-smoke or mga fumes, mga pabango, these are the elements and these are the elements, chemicals in the form of gas that passes through your lungs and your airways. Reason for you to have a greater chance compared than others na pagkaroon ng asthma. Of course, the climate change, sudden changes from lamig to mainit to malamig. Mainit can cause bronchodilation, malamig can cause bronchoconstriction. Sudden changes may result to asthma also. Air pollution and chemicals, alam na natin yan. The common signs and symptoms, of course, you have cough, you have your dyspnea, you have your wheezing, and chest tightness. Now, the reason bakit tayo nagkakaroon ng cough during asthma attack is that because our bodies, sabi ko sa inyo, they can sense that something is abnormal. And in the lungs, one way for you to expel out what is abnormal in our lungs or in our respiratory system is to reason. First is for you to sneeze, and second is for you to cough. Because that's one way for you to expel it out. Anything foreign, anything abnormal, anything that is not usual to your lungs or to your respiratory system will be expelled out through your sneeze or through your cough. Okay? Difficulty of breathing. The reason why you have difficulty of breathing, allow me to show you the picture of asthma. I'm sorry. Reason why is that because you have bronchoconstriction. Okay, buksan. Okay, so you can see my screen. Nakikita nyo naman, di ba? Now, if you are to look at this one, okay, asthma causes bronchoconstriction. This is the normal opening of your bronchi, okay? However, because of the asthma, because of the inflammatory responses, nagnanarrow siya to this and further to this. Okay? Kaya ka nagkakaroon ng difficulty of breathing because there's a difficulty of the air or of the oxygen to pass through into the lungs and carbon dioxide pass through out of your lungs. Okay? And therefore, you have a poor gas exchange which will later on will make your body malig. Kasi wala kang enough oxygen delivery sa systemic circulation mo. Okay? It is because you have least oxygen supply to your lungs that can be gas exchanged with your carbon dioxide. So usually, ang mga may asthma patient then is prone to have what? Somnolent. Pag sinabi natin somnolent, sila yung mga pasyente na madalas tutulog-tulog, drowsy, aantok-antok. The reason why? Kasi nga, there is poor entry of oxygen to your body and there is poor exit of carbon dioxide out of your body. And when the carbon dioxide, okay, stays in your body, carbon dioxide is a triggering factor para antukin ka. Okay? So that's the reason why patients with asthma, they are somnolent or drowsy in appearance. Kaya nga, di ba, pag hirap ka daw matulog, okay, pag hirap ka matulog, the most thing or the best thing that you can do is inhale deeply, okay, then exhale, inhale deeply, then exhale. Okay? So what do you do now after nun? After 3 times of doing that, you inhale less, and you inhale more and you exhale less. Okay? Para daw yung carbon dioxide least na maalis through exhale. At kapag least na naalis ang carbon dioxide through exhale, you have better chance na makatulog or antokin. It is because you have much concentration ng carbon dioxide sa katawan. Okay? So under asthma also, one of the presentation also is wheezing. Okay? Why do we have wheezing? So we all know for a fact, nasabi natin kanina, okay, nag-narrow yung inyong bronchioles and your bronchus. Pag nag-narrow iyon, okay, there's a force that would increase for the oxygen and carbon dioxide na lumabas at pumasok, okay? And that force is your pressure. It would increase the pressure. And when the pressure increases, that would create sound. And that's wheezing, okay? So, para siyang sipol. Can you imagine, pwede ka bang sumipol ng dilated ang bibig mo, nakabuka? Di ba hindi? Nakaka-create ka ng sound, it is when you narrow your lips. So, same what happens to your lung, okay? Or to your bronchus specifically. When your bronchus narrows because of the increased air pressure that needs to force out the carbon dioxide out and to force in the oxygen, nagke-create siya ng sound, which is the wheezing. Nagigets ako doon? Okay. So that's the reason why you have wheezing. With asthma, of course, it's a hallmark sign to have wheezing. Okay? It's basically, saan nyo maririnig ang wheezing? Usually, you can hear the wheezing in this aspect. Wait lang ha. Hanap tayo ng lung. Okay. Ito na lang. So basically, no. Maririnig nyo ang wheezing here. Okay? You'll hear the wheezing, okay? Wala akong maririnig na naging estudyante ko, okay? Madalas kasi may nakikipagtalo sa akin, Sir, I heard wheezes daw. Sa basal. Basal of the lungs, may wheezes. It's next to impossible na makarinig ka ng wheezes, okay? At the basal level. Okay? This, pag sinabi natin basal level, eto siya. Nakikita nyo ba? Parang hindi kayo responsive. Okay. So this is your basal level. Okay? This is your basal level. When you have asthma or when you have bronchoconstriction, from the word itself, bronchoconstriction, the bronchus and the terminal bronchus or bronchioles itself na, yun ang mariringgan nyo. So basically, eto sila. Oh. Ito yung bronchus ninyo. So dapat maririnig nyo siya sa upper portion of your lung. The wheezes are heard in the upper portion of the lungs because it is where your bronchus or bronchi are located. Okay? So dito yung siya maririnig. Ang madalas yung maririnig dito sa basal, these are rails. Okay? Or crackles. Yun ang naririnig nyo sa basal. But in the upper, these are your wheezes. Sipol ang maririnig nyo dito. Okay? So that's the reason why you have wheezing, because of the narrowing. Okay? Now, why you have cough? Binanggit ko na sa inyo kanina the reason. It is because there's something that needs to be expelled out. So, it can be in a form of phlegma, or it can be in a form of pathogens or allergens that pass through your lungs, that pass through your airway down to your lungs. Okay? Why do we have chest tightness? The reason why we have chest tightness is for 2 reasons. Okay? You experience chest tightness is because with the asthma, severe exacerbation of asthma, nagkakaroon na kayo ng accumulation of fluids. Kasi nga, di ba, nagta-tight, nagna-narrow. Pag nagna-narrow, then it's hard to have an exit also for the water retention or for the phlegm. So bumibigat ang lungs ninyo because of the accumulation of the phlegm and the water, which would result also to tightness or bigat ng dibdib. Another reason of the tightness is because of the severe bronchoconstriction. Kaya nakakaramdam kayo ng parang paninikip ng dibdib. Not because of your heart, but because of your lungs. Okay? Now, what is the severe hallmark sign for your asthma? Okay? Anyone, dun sa gumawa ng report na asthma, what is the severe form of your asthma? Yung masasabi natin na kung malala ng asthma nito. What? Wala. Cyanosis. Okay? Cyanosis, it's barrel chest. Okay, cyanosis and barrel chest can be a late stage result of asthma, but usually barrel chest would result from emphysema. Cyanosis, it is when there's too much deficiency of oxygen already. But the hallmark sign that the asthma is progressing negatively is the absence of is the absence of lung and breath sounds. Why? Sabi ko nga sa inyo kanina, there is a bronchoconstriction, okay? When there's a bronchoconstriction, it produces high-pitched sound na parang sipol. However, okay, kapag hindi na siya bronchoconstriction, bronchclosure na siya. What do we mean by that? Yung sobrang constriction ng bronchus ninyo, nag-result na ng closure ng inyong bronchus, there will be no sound produced anymore. Try yung sumipol. After yung sumipol, try yung sumipol ng sarado ang bibig, ang labi. If you can notice, no sound will be produced when your lips are already closed trying to make pitch. Diba? So same with your bronchus. Okay? Kapag wala ng sound na nare-release upon auscultation, it is one way to tell you that the lung is now that the asthma is progressing negatively. Okay? Kasi wala na siyang sound na na-produce simply because nagsasara na ang bronchus. And later on, you'll see na sobrang hirap na siyang huminga kasi wala ng oxygen na pumapasok, wala na din carbon dioxide na lumalabas, so ini-increase na yung tulog niya. And then cyanosis, because wala ng oxygen supply sa all throughout ng body niya. And then nagkakaroon na siya ng shock because there's a buildup of acid in the form of carbon dioxide because carbon dioxide will be transported into carboxyl acid. Okay? So, kaya yung reason na marami ding namamatay because of asthma, it is because it left untreated and uncontrolled. Okay? We all know for a fact also that asthma, it is a lifetime na sakit, okay? It is proven by science. However, there are some testimony that says that they had asthma when they were young, but it resolved when they got old. Okay? Kasi yung kapatid ko, yung kuya ko, ganon. He has asthma when he was young. He had asthma, should I say, when he was young. And then na-resolve nung tumanda na siya. However, ang sabi nila, it was not actually resolved. Okay? Because it wasn't an asthma to begin with. It might be just an allergic response, but not asthma. Okay? So yung sabi ng doctor sa amin before. Okay? Now, it may not be curable, okay? Kasi for life mo na siyang dala, but it is manageable. So meaning the signs and symptoms can be controlled, okay? So we have ways to control it. Of course, there are some medications like inhalers, the common ones, okay? Exercise, healthy lifestyle, nutritional diet. So these are the ways that we can manage the signs and symptoms, okay? Now the diagnostics. Nabasa ko dito sa report that you have spirometry. Okay? So, but I have also read here the treatment peak flow meter. Peak flow meter is never a treatment for asthma. Piclometer is actually one way of telling whether your lung is of good condition. On how you do the piclometer. Piclometer is usually used, meron kang parang apparatus should I say, na piclometer ang tawag natin doon. So, kapag ikaw isang asthmatic, you are diagnosed to be asthmatic or you are diagnosed post-asthmaticus, pag dinischarge ka, usually, ina-advise ka mag-piclometer sa bahay. So, anong ginagawa ng piclometer? Yung piclometer na yon, okay, mag-inhale ka forcefully, okay? After that, ipapasok mo, ibabite mo sa lips mo yung piclometer and then ibubuga mo the fastest and the strongest you can. Okay? And then may kulay siya. Okay? Sa ibang bansa may kulay siya. Sa Pilipinas, hindi ko alam kung available na yung may kulay. Ang available yata sa atin yung may numero. Okay? So, usually, pag nagkulay red siya, ibig sabihin you have a poor lung. Okay? So, it may give you na meron kang unresolved asthma. Pag nagkulay yellow naman siya, it would mean that you have a good asthma prognosis but not manageable. So, ibig sabihin, we need to improve medications or we need to modify certain medication and certain treatment. Kapag nag-green siya, then it means that you have a good lung. So, if you have a good lung, ibig sabihin, yes, you have asthma, but it's manageable. Okay? Yung spirometry naman, usually ginagawa siya sa pulmonary department, kung saan pahihingahin ka nila ng malalim, yung pinakamalalim at pinakamalaking hinga mo, and then may malaki siyang spirometer, doon mo ibubuga forcefully ang iyong in-inhale. At doon malalaman nila kung gaano kalakas yung iyong pagbuga or yung tawag ito, forced expiratory volume mo. Okay? So, malalaman nila doon na kung gaano karami yung na-inhale mo, dapat ganun din karami na exhale mo. So, malalaman nila na kung ganun kalaki ang na-exhale mo, okay, ganun kalaki yung capacity na kayang i-accommodate ng iyong baga. So, kung malaki yung kayang i-accommodate ng baga mo, ibig sabihin, malaki yung expansion ng baga mo. At kung malaki expansion ng baga mo, ibig sabihin, maganda yung airway mo, patent yung airway mo. So they can diagnose whether you have an asthma or wala. Okay? Now, yung FeNO test, yung F stands for, hindi ako sure kung functional or fractional, tapos yung E is for expired. Functional or fractional expired nitric oxide. Okay? So, bakit may measurement ng nitric oxide? Kasi, kapag meron kang bronchoconstriction, okay, nagkakaroon ng catabolism ang iyong lung. Okay? In cope with, in adaptation or in cope with the accumulation of your carbon dioxide. Now, pwede naman ang i-measure natin ay yung iyong carbon dioxide, but that's through capnography. Pero para magawa yung capnography, meron ka kailangan i-insert na tubo sa bibig, parang intubation. Pero dito sa fractional expiration nitric oxide, kailangan mo lang mag-exhale. At ang i-measure na sa exhaled air mo is to measure the nitric oxide. Pag mataas ang nitric oxide, then it would correspond na you have inflammatory processes sa iyong baga and may later on describe as asthma or not. Okay? So, yun yung ginagawa ng FeNO test. Okay? So, in treatment, you have corticosteroids. We all know what steroids does. Okay? The steroids bronchodilate. Okay? Your bronchoconstricted bronchus. Okay? Cromolyn sodium, the purpose of cromolyn sodium is same way, but in a way that it targets the sodium transfer. Okay. Then you have also your anticholinergics. So usually your anticholinergics is innervating your parasympathetic response. Kapag nagkaroon ng parasympathetic response, then this is the time na ikaw ay nagkakaroon ng xerostomia, natutuyo. So kapag natutuyo, walang masyadong phlegm na nabubuo. So it would eliminate the chance of having chest tightness or the chance of having phlegm. So therefore, the chance of having cough would also be resolved. Okay? So nakita ko yung ibang pathophysiology. Hindi nyo naman to sinerch ang ayos. But then anyway, that's asthma. Okay? So now, next is chronic obstructive. Okay? Or COPD. So yung COPD, it is a preventable and treatable slowly progressive respiratory disease. So ibig sabihin, it is chronic. Okay? Kasi matagal na siya. Super tagal na untreated. Okay? But it is manageable. Okay? Kaya naman preventable sana. Okay? However, in the terminal end or in the longest time na hindi mo siya minamanage and you are not sparing or withholding the practices you had which lead to COPD, then it may progress to worse condition. Yung binabanggit kanina ni Servo, COPD, okay, usually emphysema, okay, barrel chest ang kanyang hallmark sign. Okay? Ano itsura ng barrel chest? Ganito itsura ng barrel chest. Barrel chest. This one. So ito itsura ng barrel chest. Okay? This is a normal chest and this is the barrel chest. Okay? How are you going to identify whether your patient is barrel chest? Hindi dahil sa exercise. Because we have patients usually, ganito ang dibdib nila simply because they were active in exercise or gym when they were young, or they are active still ngayon. The difference with the barrel chest na cause of the COPD or emphysema is that yung barrel chest, wala siyang cleavage. Walang cleavage sa pagitan. Okay? Kapag ito ay cause ng exercise, may cleavage sa pagitan. Parang ganito. Saan ba yun? Ayan may cleavage siya. Barrel chest daw yan pero hindi yan barrel chest kasi may cleavage siya. Okay? If there's no cleavage, then therefore, that's barrel chest. Okay? Ayan, may cleavage So that's not barrel chest. Barrel chest is the protrusion of your chest but has no cleavage. Okay? Wala siyang cleavage formation. Ayan. Okay? So ito yung barrel chest. Mukha siyang barrel kasi. Okay? What causes the barrel chest is of course your COPD, chronic obstructive pulmonary disease, is no longer bronchoconstricted. Instead, it's continuously bronchodilated na. Okay? So, nag-i-increase ang pressure. Pag nag-i-increase ang pressure, nag-i-stay na lang doon yung pressure. And that the pressure equalizes na doon sa loob ng iyong lung, which results to the expansion of your chest. Okay? So, may mga causative agent na binanggit, Haemophilus influenzae, Maricela catarrhalis, and Streptococcus pneumoniae. But usually, these are not the cause of your chronic obstructive. Okay? Your chronic obstructive is more of your environment and more of your lifestyle practices. You're smoking, working in a factory that has fumes, has usok. So usually, ito yon. Okay? And the causative agent that I mentioned, yung influenzae, Maricela catarrhalis, Streptococcus pneumoniae, these are actually causative agents that may lead to inflammatory processes, okay? Which is bacterial, okay? Na mag-worsen ng COPD ninyo. But basically, these are not the cause of your COPD. Okay? Risk factors na binanggit dito, one is the alpha-1 antitrypsin deficiency. Yung alpha-1 antitrypsin, okay, or A1A, okay, usually this is a protein derivative na nirelease ng inyong liver. Okay? The purpose of the alpha-1 antitrypsin, diba, is to protect your lungs. Okay? However, if you have deficiency to this, then you have a deficient protection for your lung, and which may result to COPD. Okay? So if you have liver problem, if you have read any questions that says about liver, okay, liver condition, you also check that there might be lung problem because of the alpha-1 antitrypsin. Okay? So of course, you have chronic cough. Yan yung mga signs. Sputum, okay, of course. Phlegm kasi nga hindi na nagko-constrict and dilate ang ang iyong bronchus or yung bronchios. Nag-stay na siyang constricted or nag-stay na siya na dilated. But usually in the long run, supposedly COPD chronic obstructive. So supposedly dapat nagko-constrict na lang siya, okay? However, in the long run, nagme-maintain na siya as dilated. That's the reason why in the COPD, meron kang dalawa. Meron kang pink poppers and blue, ano nga yun? Pink poppers, wait lang, search.
Blue.
Ano na?
Blue.
Blue.
Bloaters po.
Bloaters.
Bloaters.
Okay? So pag sinabi natin pink poppers, sino itong mga to? Sino itong mga to?
May emphysema po.
Okay. May emphysema, why? Analogy, why?
Kasi po nagkakaroon ng distraction po sa alveoli.
Huh?
Charot.
Ano? Bakit?
Cyanosis.
Pag pink puffers ka, may dalawa kasi to chronic bronchitis and the emphysema. Pag pink puffer ka, okay, hindi ka nagiging cyanotic. Ikaw ay medyo namumula. Okay? Kaya nga pink puffer. Okay? Kaya ka nagiging kulay pink, it is because you still have oxygen supply. Okay? But, yung oxygen supply mo, sinasabi ko nga sa inyo pag emphysema, okay, pag emphysema, beginning niya is you have bronchoconstriction. But in the long run, you have bronchodilation na. So, nakadilate na lang yung bronchus mo, free-flowing na lang yung oxygen and carbon dioxide mo. Pero dahil free-flowing na lang siya, dapat kasi may pressure pa rin to release, to exhale, and to inhale. Pero in the pink puffer, in the COPD, emphysema specifically, wala nang ganung pressure na nakikreate. It is because wala nang contraction, ng dilation, and constriction ang iyong bronchus. Ano na lang siya, freely open na lang siya. So kapag freely open, freely passing through, and freely passing out na lang yung oxygen and carbon dioxide. So nagkakaroon pa rin ng gas exchange, okay? Nagkakaroon ng gas exchange. That's the reason why hindi ka nagkakaroon ng cyanosis. So, marami yung blood supply mo because of that kasi pwedeng mas marami pumapasok ng oxygen than the carbon dioxide na lumalabas. Kasi remember, yung nasa loob ng lungs mo, since maintained na yung kanyang opening, as is na yung kanyang dilation, okay? Walang masyadong pressure from the lungs that can force out the carbon dioxide through exhale. But your oxygen, okay, you still have pressure sa iyong environment that can inhale in the oxygen. Kaya maraming oxygen ka ngayon sa katawan mo. So you are hyperly oxygenated. Okay? That's the reason why you are pink in appearance during your emphysema stage. Okay? The opposite naman, yung chronic bronchitis or the blue bloaters, okay? Sila naman tong kaya sila bloaters kasi sila yung mataba. Okay? Sila yung mataba, sila yung cyanotic. Of why they are cyanotic? Because in the stage of chronic bronchitis, hindi naman sila maintained bronchodilated. They are maintained bronchoconstricted. Pag bronchoconstricted, there is minimal entry of your oxygen and increased build-up of your carbon dioxide. When there's increased build-up of carbon dioxide, okay, that would result for you to be bloated. Okay? Why? Kasi naiipon sa iyo the oxygen naiipon sa iyo is of course yung bigat ng carbon dioxide because we all know for a fact that carbon dioxide is much heavier or should I say heavier than your oxygen. Molecule count pa lang ang gagawin natin, di ba? And they remain cyanotic, it is because minimal oxygenated blood is circulating to your body. Why? Kasi nga, konti, minimal to zero ang pumapasok ng oxygen sa ating katawan because of the constriction. At what happens is the buildup of carbon dioxide sa katawan. Okay? So sila din yung mga somnolent, okay? Sila din yung mga antuke. Okay? So emphysema naman, okay? Sila naman ay mga payat. Okay? Why they are payat? It is because free-flowing nga lang ang carbon dioxide at ang iyong oxygen. Okay? So do you understand what's the difference? Pag sinabi natin pink popper, emphysema. Pag sinabi natin blue bloater, chronic bronchitis. Pag sinabi natin emphysema, bronchodilated in the long run. Pag sinabi natin chronic bronchitis, bronchoconstricted in the long run. Okay? Pag sinabi natin emphysema, sila yung mga pink poppers, kulay pink ang kulay nila at payat sila. Pag sinabi natin chronic bronchitis, sila yung mga matataba at cyanotic sila, blue bloaters sila. Okay? Okay. Next is chronic bronchitis. Acute bronchitis, it is because saglit lang siya. Okay? But it doesn't mean hindi siya malala. Okay? Meron kasing acute bronchitis in severe exacerbation. So meron nun. Okay? So ibig sabihin malala siya. Acute bronchitis may be termed also as ATB or acute tracheobronchitis, which means that the affectation is not limited only to your bronchus, but affects also your trachea. Okay? Kaya siya acute tracheobronchitis. But the manifestation, the only difference is that your trachea is near to your what? Ano ba ang trachea?
Airway, sir. Yung pipe.
Yes, it's part of your airway, but what is trachea?
Yung ano, sir. Yung siya yung nakakonect sa lungs.
Ha?
Pipe po, sir. Yung pipe. Konektado sa bronchi. Bronchioles.
When you talk about trachea, it is something near. It's part of your airway clearance. Part of your airway, opening of the lungs, okay? It's near to your pharynx. Okay? Larynx, should I say. And the larynx is your voice box. Tama? Trachea is responsible for the passage of air, which would help your larynx to produce vibration. And that's the one way for you to make sound, to make voice. Now, if your trachea is being affected with inflammation, kaya ang acute tracheobronchitis din, isa din sa mga hallmark sign, paos. Okay? Kaya hindi din paos or hindi nakakapagsalita ang pasyente. Okay? Because the trachea is being affected and it is very much adjacent only to your larynx or your voice box. Okay? Pag hindi apektado ang trachea, acute bronchitis lang, then you don't have hoarseness of voice na mananote. Okay? Chronic bronchitis, nabanggit na natin, it's blue bloaters. So that's for chronic bronchitis. The medication usually, of course, almost same with asthma. Okay? Except for some certain antibiotics, usually, ano bang antibiotics for bronchitis? Ano antibiotics for bronchitis usually? Or for lung? Wala. So usually mga amoxicillin, penicillin, yan yung usually mga lung antibiotics. Okay? So usually ang tinitreat kasi nila doon, yung bacterial. Bacterial that causes your itis, your inflammation process. But if the inflammation process is not caused by bacterial, then usually rest. Because kung viral yan, self-limiting. Okay? Pneumonia. Ito yung binabanggit tawag nito, ni Miggs. Okay? Whether pneumonia is usually always caused by a certain causative agent. So, pneumonia, yung mismong disease process, okay, or yung mismong disease diagnosis, it is usually caused, of course, by S. pneumoniae, Streptococcus, okay, gram-positive, which causes pneumonia or pneumonitis technically. But the pneumonia itself, as a general term, it is a representation that a fluid accumulation is occurring in your lung. Okay? So, pneumonia, as a diagnosis, as a medical diagnosis, okay, it is caused by a causative agent, which is Streptococcus pneumoniae, gram-positive. Pneumonia, as a sign and symptom, okay, it is a definition that asserts accumulation of fluid in your lung. Okay? So that's the difference between pneumonia as diagnosis and pneumonia as a sign and symptom, as symptoms. Okay? Now, there are, sabi dito sa inyo, there are 3 types of pneumonia. So first, we have the CAP, or the community-acquired pneumonia. So we have the second, the healthcare-associated pneumonia. We have the third, the hospital-acquired pneumonia. And of course, the ventilator-associated pneumonia, or the VAP. So, etong mga to, these are all types of pneumonia, but speaks only the origin kung saan nakuha ang pneumonia or saan nagkaroon ng problema kaya nagka-pneumonia. Because Streptococcus pneumoniae, okay, that particular causative agent is normally present in our airway clearance, specifically in our upper airway clearance. Okay, the purpose of this is, of course, it helps in the protection of our airway clearance from foreign pathogens. However, kapag na-dislodge ito, ibig sabihin, lumipat ng area, ibig sabihin, nalaglag sa ating lower respiratory tract, it causes pneumonia. Okay? So, give me another normal flora that causes problem. Kapag na-dislodge o nalipat ng ibang area ng katawan. Give me. Oy! Ano? Tinuturo yan sa inyo, sasaktan ko kayo.
Gastro, sir.
Ha?
Gastro.
Alin?
Gastro.
Sa gastro, ano sa gastro? Ano sa gastro?
Mali pala. Sir, wala na.
What? Another?
E. coli, sir. Yun pala.
O, saan ang E. coli? E. coli is a normal flora in your GI tract. Pero kapag na-dislodge, for example, sa inyong
Stomach.
na-dislodge siya sa iyong stomach, nagkakos siya ng irritations. Pag na-dislodge siya sa inyong urinary tract, nagkakos siya ng UTI. So, same with your ano nga ito? With your Streptococcus pneumoniae, okay? Normal flora siya, it helps to serve as line offense ng katawan mo. However, if this dislodges your lower respiratory tract, it leads to pneumonia, okay? Now, sinabi natin merong apat, you have the CAP, the community acquired, okay? So usually it happens in the community, okay? So the origin kung bakit pinagkaroon ng pneumonia, it is because of the community settings. So may maduming community, there's a massive infection in the community, and then you get infected, and because of the infection, it leads your Streptococcus pneumoniae to be dislodged sa iyong lower respiratory tract, which is pneumonia. Healthcare associated, usually ito yung sa mga healthcare facility. So anong difference sa hospital and healthcare? Usually they are both the same naman, okay? The only difference is that yung hospital is specific sa hospital. Yung healthcare, it can be in a hospital clinic, in a school clinic, in a company clinic, okay? Or in any healthcare procedure na ginawa. So like for example, nagpa-swab ka sa company, okay? So it is a healthcare procedure, di ba? So dahil nagpa-swab ka, nagkaroon ng chance na magkaroon ng dislodgement, okay? And nagcause ng pneumonia. It didn't happen in the hospital. So it's a healthcare related. Okay? It's not hospital related. And yung ventilator associated, usually kasi yung mga naka-ventilate, yung mga tawag dito na intubate, nadidislodge yung kanyang pneumonia kasi ikaw ba naman tusukan ng tubo, di ba? So pag tumusok ang tubo, lalo na kapag yung tubo sagad doon sa airway clearance mo, sakto yung circumference, then madidislodge talaga yung Streptococcus pneumoniae mo papunta sa lung, which would result in pneumonia. Okay? So that's pneumonia. The presentation kapag lung, halos pare-parehas lang. Okay? Cystic fibrosis. Okay. So cystic fibrosis, commonly known as CF, okay, it is an autosomal recessive disease. Pag narinig yung autosomal, okay, ang ibig sabihin ng autosomal, for you to have a particular disease in manifestation sa'yo, dapat both of your parents has that particular genes. So, ibig sabihin, kung yung mother mo, merong gene nito, pero hindi siya manifesting, kasi nga, yung lolo mo, yung tatay at nanay niya, okay, isa lang sa kanila ang may ganung particular gene. Ngayon, sa level mo, kapag ang mother mo may ganung gene, tapos yung father mo may ganung gene, okay, parehas silang may ganung genetic makeup, ikaw ang makakamana ng cystic fibrosis. Okay? So, kapag sinabi natin autosomal recessive, dapat both of your parents, both of your mother and father, may ganung gene. They both have no manifestation, okay? But you will have the manifestation since both of your parents has, ikaw ang makakamana. Okay? So, cystic fibrosis. So, ano nangyayari sa cystic fibrosis? Merong problem doon sa sodium exchange. Okay? So, doon sa sodium exchange kasi, nagka-problema because of the cystic fibrosis gene. Okay? At yung transcription niya is yung CFTR. Ngayon, dahil may problema doon sa sodium exchange, lahat ng mga mucus mo, lahat ng mga area na merong mucus production, that includes your mucous membranes ng mouth, okay? Ng iyong gastrointestinal, ng iyong lung, nagkakaroon ng thick mucus secretions. Ngayon, kapag masyadong thick ang mucus secretions mo, madikit pa siya sa paste. Alam niyo yung itsura ng paste? Yung pandikit. Okay? So, pag masyadong madikit yon, okay? If it travels to your body, okay, pwede siyang makabara. At kapag nagkaroon ng pagbabara, and that would account to certain problem. So, depende. Kapag yung thick secretions bumara sa iyong lung because nandun yung production ng secretions, and then you have a lung problem. Kapag ang pagbara ay nangyari sa iyong abdominal, and then you'd have abdominal problem. Diba? So, pwede kang magkaroon ng constipation, indigestion, kaya medyo deadly ang cystic fibrosis. But cystic fibrosis, it is not a disease that can be acquired, okay? It is usually what? It is usually inborn. Okay? So that's cystic fibrosis. So usually, hanggang 18 years old ang ata ang tinatagal to 22 years old ang may mga cystic fibrosis. Okay? And usually ano lang ang medication sa kanya is not the treatment of the disease itself, rather management of the presentations or the signs and symptoms. Yun ang ginagawa sa cystic fibrosis. So madalas sa cystic fibrosis ang ginagawa lang natin ay tawag dito attendance sa signs and symptoms but not treating the disease. Okay? PDF. Now, let's talk about cryptogenic organizing pneumonia. Noon, mas kilala to, siguro mga panahon nila Sir Manaloto, mas kilala nila itong bronchiolitis obliterans. Even our batch knows this as bronchiolitis obliterans. Pero sa batch nyo, it's COP na nga, cryptogenic organizing pneumonia. It's no longer bronchiolitis obliterans organizing pneumonia or BOOP or BOOP. Okay? So it's idiopathic daw, okay? Why idiopathic? Pag sinabi natin idiopathic of a known reason, okay? Of a known reason, ibig sabihin of a known etiology. So walang established reason kung bakit nagkaroon ng particular na pneumonia na ito. But there are some certain theory that say that accounts reason kung bakit nagkakaroon ng ganitong pneumonia. So it's cryptogenic, it's cryptic, di ba? Parang mga cryptic message, hindi malinaw yung dahilan, pero merong pinatutukuyan. So it's cryptogenic organizing pneumonia. Okay? Causative agent, hindi nga natin ma-identify, that's the reason why it's idiopathic. Okay? So, isa sa mga hallmark sign nito, it's a non-productive cough. So, if it's pneumonia, okay, there is accumulation of fluids or phlegm, diba? Kasi nga pneumonia. Pero, why is it non-productive cough? Okay? Because the level ng kanyang yung level ng fluid accumulation niya, okay, is at the same with COVID-19, generally it's at the level of your alveoli. Okay? Pero pag lumagpas sa alveolar kasi, sa alveoli sac nyo, lumabas sa alveolar sac niyo, nag-accumulate na siya sa lung, parenchymal niyo, that's when pneumonia begins. Pero dito, you have pneumonia evident in your alveoli or alveolar sac. Okay? And that's the reason why wala siya talagang, hindi siya productive cough. Kasi nandun siya sa level na yon. Pwede siyang extravasate outside of your pulmonary cavity, but never from your lung out of your airway clearance. Okay? So, common signs and symptoms, yun nga, non-productive cough, the fever, of course, because of the infection or because of the inflammatory process. This nga, we all know for a fact, kapag may pneumonia, there is poor gas exchange, which may lead to difficulty of breathing because you are trying to cope dun sa kulang ng oxygen at sobrang carbon dioxide. Body malaise because of your poor systemic circulation ng oxygenated blood. That's the reason why you have body malaise. Weight loss, you have weight loss kasi nga yung mga cells, system cells mo is nagkakaroon ng exhaustion. So nagkakaroon siya ng catabolism or catabolic metabolism. So nagkakaroon ng cell wasting, to tissue wasting, to muscle wasting. So nagkakaroon ka ng weight loss. Okay? Isa sa mga mahalagang gusto kong makita niyo dito sa cryptogenic pneumonia, isa sa mga test na ginagawa sa kanila is yung ESR or erythrocyte sedimentation rate, I believe. Okay? So sa ESR, anong ginagawa? Nagko-collect sila ng blood. They put that in the yung lagayan nila, a test tube-like na lagayan. And kapag mabilis mag-settle ang erythrocytes, which is your RBC, sa bottom nung test tube na yon, it's tantamount to diagnosing na merong infection, okay? Because when there is infection, mas mabigat ang red blood cells ninyo. Kaya yung ESR or sedimentation rate ninyo mabilis. Pero kapag free-flowing lang siya, then therefore there's an infection process. Okay? So, hindi siya mabilis lumubog doon sa bottom. Remember, your blood consists of ilan elements? It consists of formed elements and fluid elements. Diba? You're fragmented sa anatomy physiology. Remember? Hindi nyo naalala. Okay. Next is bronchiectasis. So what is bronchiectasis? So bronchiectasis is a chronic irreversible dilatation of the bronchi and bronchioles due to associated chronic infection that causes destruction of the airway walls. Severe repeated respiratory infection is the common cause of bronchiectasis. So yung bronchiectasis, usually, it is actually the severe form of repeated bronchitis, repeated pneumonitis. Basta repeated infection of your lung may lead to bronchiectasis. Why? Kasi kung palagian siya nagkakaroon ng bronchoconstriction, tapos magdadilate bronchoconstriction, tapos magdadilate bronchoconstriction, eventually, nagluloosen na yung muscle ng ating bronchus and bronchioles. Pag nag-loosen na yung muscle na yon, nagiging keep dilated na lang siya. Parang kapag ikaw ay nag-gym, habang tumatanda ka, pag hindi mo na maintain ang gym mo, okay, naglulusen siya. Kaya kung nakikita niyo mga nag-gym noon, nagigilaw-law na kanilang mga muscles and fats. So same thing happened with bronchiectasis. Okay? Dahil palagian, nag-constrict, nagdadilate, nagdadilate, and because of the infection, it happens because of infection, nagiging keep dilated na lang siya, parang emphysema. Okay? Kaya nga, bronchiectasis, stasis, stay as is. Okay? So, yun ang bronchiectasis. Okay? So, kung bronchiectasis dilated, ang kanyang presentation is almost the same of the emphysema or pink puffer. Okay? The difference lang is that meron siyang productive cough. Of why meron siyang productive cough? Kasi meron pa rin siyang inflammation process. Okay? Tandaan nyo lang, bronchiectasis, stasis, may IS sa dulo, meron pa rin inflammation. Okay? So, that leads to production of sputum or of phlegm, which result to productive cough. The same goes, may dyspnea pa rin, may abdominal breath sounds, but here, nakikita nyo, walang wheezes, okay? But merong crackles and rails. Why? Kasi nga merong production ng sputum and phlegm, which in yung water, di ba, usually, by gravity, by pull of the gravity, magstay siya sa bottom, sa basal part of your lung. Kaya andun ang crackles and rails. Okay? So hypoxemia, notable pa rin. Hemoptysis could be one. Why? Because kailangan mo nga ng pressure para mailabas yung productive cough, di ba? So because of your forceful coughing mechanism, nagkakaroon na ng sugat ang iyong airway clearance, which would mix with the sputum and evident as hemoptysis. Cyanosis is a common thing pa rin kasi syempre you have decreased oxygen supply to your system circulation na, and then worsened kapag worsened condition with manifest clapping of fingers. So bakit nagkakaroon ng clapping of fingers? Because of the decreased oxygen supply to your peripheries, specifically to your fingers. At kapag nagkakaroon ng ganon, decreased supply of oxygen, nagkakaroon ulit ng catabolic metabolism or catabolism, and the catabolism would result to your lactic production, okay? Anaerobic anaerobic processes, and nagkakaroon ng shortened ligaments, kaya nagkakaroon ka ng clubbing of fingers. Okay? So, yun ang mga general manifestations ng bronchiectasis. Okay? Next is you have your tuberculosis. So, you have tuberculosis. You all know already what is tuberculosis. Okay? See, tuberculosis, it is not only limited to your pulmonary tuberculosis. The tuberculosis caused by Mycobacterium tuberculosis, some Mycobacterium tuberculosis, okay, can travel outside of your lung. Kaya nagkakaroon ng bone TB, okay, orthopedic TB. So, nagkakaroon din ng iba pang organ. Kung saan nalagay ang TB na yun, saan na nag-migrate, saan nag-mature, yun ang kanyang diagnosis. So like for example, the tuberculosis, usually alam natin TB, pulmonary tuberculosis, but there are some other forms of tuberculosis. Depende kung saan siya mag-mature. Okay? So it attacks your normal cell, and when it attacks your normal cell, it leaves a permanent scar. Okay? Sa iyong parenchyma. So to your lungs, for example, it leaves a permanent scar there. Okay? But it doesn't mean that because you have a scar, you are contagious. Because there are two stages of your TB. So you have your latent and active. Kapag latent, ibig sabihin previously you had, you are not that infectious or contagious as of the moment. But you have a chance na maging contagious when you move to active stage or active tuberculosis. Okay? Sir, kapag latent ba, pwede pa maging active? Yes. Kapag, remember, tuberculosis is a form of an opportunistic bacteria. When your immune system is down, okay, active na naman sila. Okay? May not be as active as it was previously. However, kapag sobrang depleted ang iyong immune system, maybe because you are a CKD patient, you are an HIV patient, or you have some other comorbidities, diabetes mellitus, chronic, uncontrolled, hypertension, chronic and uncontrolled, then pwedeng mas lumala pa ang Mycobacterium. Why? Because knowing for a fact that you have other comorbidities, you would be taking other medications. And some other medications, despite of their good intentions to your body, okay, they leave some certain adverse effect, which may decline your immune system. Okay? Now, what I would like to remember here is that why you have night sweat. Okay? You are having night sweat, usually pagdating sa hapon doon ka nagkakaroon ng lagnat or sa gabi, because Mycobacterium tuberculosis, they are more active in a cold environment. Okay? So they are more active doon sa gabi because that's where your body is in heat. Okay? Sir, parang baliktad. Okay? Yung Mycobacterium tuberculosis, they are more active sa gabi. It is because your body is in heat. Why? Your body is in heat sa gabi. It is because you are reserving your, you are, fighting against the lamig ng environment. So you have more metabolism inside your body when you're actually at rest sa gabi. So that's the reason why you have night sweats and night fever. Kasi doon sila mas active. Okay? I also would like you to take note of the parang yung pinaka hallmark na or gold standard ng diagnosis ng tuberculosis is the quantiferon TB gold test. Yung QFTG kasi, yung quantiferon TB gold test niya, it is in a form of collecting a blood sample, and in the blood they try to note whether there is the presence of Mycobacterium tuberculosis. So when there is, then it means it's active kasi nga nagsisirculate eh. And then it means you are infected also. Now, another test na madalas lumalabas sa board exam is the tuberculin skin test. Okay? So marami nagkakamali dito. Kasi meron nagsasabing it's tuberculin skin test, meron nagsasabing it's a MAN2 test, meron nagsasabing it's a PPD test. Okay? Now, the interchangeably siya nagagamit, okay? Ang MAN2 test, okay? Ang MAN2 test, it is the process or the way on how to do the test. The tuberculin and the PPD or the protein derivative, okay? This is actually the fluid that is being inserted or being injected intradermally. Okay? So, basically, ang talagang general term niya is tuberculin skin test. MAN2 test is the process on how you do it. The protein derivative, it is the fluid or the reagents that you are injecting intradermally. Now, paano ba nag-work ang tuberculin skin test? Ang tuberculin skin test, nag-work siya, mag-i-ingest ng protein derivative nga, okay, or the tuberculin nga, i-ingest siya dito sa iyong arm, okay? Okay, anong arm nga ito? Dorsum. Sa ventral portion of your arm, okay? Ito siya. PST. Tuberculin. Okay. Para siyang skin testing, okay? Gising pa ba kayo? Napagod ba kayo sa ano nyo? Sa klase nyo? Nung nakaraan? Anong klase nyo nga? Anong klase nyo bago ito?
Hindi naman, sir.
Ha?
Hindi naman.
Parang pagod kayo eh, kahit di kayo nag-klase. Char. Okay. So ito yung ito yung TSE or tuberculin skin test, okay? Okay, the procedure or I mean the technique is MAN2, okay? MAN2 test ang tawag. Yung pinasok nating fluid is actually your protein derivative or short term din yan. Other term yan sa protein derivative is tuberculin. Kaya tuberculin skin test ang tawag talaga and the general, okay? So magpo-form ka ng ganyan, ng wheel, okay? Now, in the formation of the wheel, okay, dapat magkaroon ng induration. Yan ganyan, okay? So what you do now is i-maintain mo lang siya na na ganyan. After 48, I think 2 days to 3 days, so 48 hours to 72 hours, after maglagay ng ganyan, babalik ka doon sa doctor mo o kaya sa nurse mo, sa any healthcare professional na gawa nito para pabasahin. Now, if after 48 to 72 hours, lumaki ang wheel mo, okay? It's identified as you are infected. Okay? However, it can only tell that you are infected, but it cannot tell whether you are infected because you were previously infected or you're infected because you are currently infected. It can only tell na nagkaroon ka ng exposure or you are exposed to TB or to Mycobacterium tuberculosis. But it can tell whether you are latent or active. Latent ka yung noon nagkaroon ka na but you have resolved already. And active yung currently meron ka at you are infectious. Okay? Now may measurement yan. If yung sukat magmula dito hanggang dito ay lumaki ng for example greater than 5 millimeters, but you don't have any exposure, you are healthy, you don't have any problem, then you are negative. However, if you have greater than or equal than 5 millimeters na laki ng induration, and then you are HIV patient, you are CKD patient, you have any other comorbidities, then that would mean na ikaw ay infected. Okay? But if the size is big, super big, like for example, 10 millimeters or 15 millimeters or more, okay? So, regardless kung ikaw man ay healthy or not, that would mean na you are infected. But again, it will not tell whether you are infectious or not. It will only tell that you were exposed or you are currently exposed to Mycobacterium tuberculosis. So that is MAN2 test. That's the technique. The fluid is the protein derivative or tuberculin, and the total procedure or the test itself is basically termed as tuberculin skin testing. So same as skin testing din siya. Ang way niya. So ganun ay itsura niya. Okay? So common naman na gamot natin dito, meron tayong 4 na ginagamit dito. Yung first line anti-tuberculosis medication. So we have the isoniazid, we have the rifampin or the rifadin, we have the pyrazinamide, and the ethambutol. Okay? Now, gusto ko lang matandaan nito, yung isoniazid is commonly related, nalabas sa board exam, isoniazid, usually ang affectation nito visual. side effects nito. Okay? Tandaan nyo lang, isoniazid, I. Isoniazid, I. Visual affectation. Ang kanyang, tawag dito, ang kanyang problem or kanyang adverse effect. Another is yung ethambutol. Yung ethambutol nyo rin, kapag wala sa choices ang isoniazid, like for example, there's a question, among the anti-TB drug medications, which affects your visual acuity? Wala sa isoniazid ang option. The next answer is ethambutol. Okay? Why ethambutol? Same with isoniazid. Tandaan nyo lang E for I. Okay? E for I. So, yun ang nakakos ng inyong problem. Rifampicin. Rifampicin, I'm not sure kung side effect ng rifampicin ay ano. Wait lang. Common. Yeah. Okay, naalala. Ang rifampicin common niya na ginagawa ay ang inyong constipation. Okay? So, yun ang kanyang common side effect. Muscle weakness is by pyrazinamide. Okay? Hindi kayo responsive, ha?
Okay po, sir.
Another thing pala, kapag nagkakaroon ka rin ng ng dark yellow doon sa doon sa iyong urine kapag ikaw ay nag-treat ng TB. It's a normal response, okay? But usually ang nagko-cause noon ay ang iyong rifampicin. Okay? Yung iyong rifampicin, kapag wala sa choice ng rifampicin, yung isoniazid. Okay? Ang pyrazinamide, ang responsible niya is yung muscle weakness. Tandaan nyo lang, di ba you have your deltoid muscle which is triangle in portion, pyrazinamide pyramid, triangle muscle. Okay? So kapag nagka-encounter kayo ng questions, what causes muscle weakness in a TB patient taking anti-TB medication? Automatic, pyrazinamide. No other options. Kapag pinapili, for example, visual acuity, and then parehas present sa option ng isoniazid at ethambutol, the correct answer is isoniazid. Okay? Kasi tandaan nyo, visual, it's I, mas madaling, ang I mas katunog na, ang isoniazid mas katunog na I, yon ang choice. But if the choices are, if isoniazid is not in the choices, then ethambutol, E for I. Okay? Ano pa ba? Rifampicin naman, it makes your urine, dark yellow or amber, brown, or orange in color. It's a normal response, okay? But if rifampicin is not available in the option, yung urine may isoniazid. Okay? What I'm trying to highlight, these are the common aspect sa board exam question nyo na niroroot nila from a certain diseases. Kaya tandaan nyo yan. Question. Following anti-TB drugs associated with major visual side effects: A. Isoniazid, B. Rifampicin, C. Ethambutol, D. Pyrazinamide. The correct answer is isoniazid. Okay. Pneumothorax. So, pneumothorax, it's a partial total collapse of your lungs due to accumulating pleural space. Okay? Ang pneumothorax, minsan na pagkakamali natin to sa atelectasis. Okay? So, what's the difference between pneumothorax and atelectasis? Okay? Yung atelectasis, merong lung collapse. Okay? But, there's no invasion of the pleural space. Pag may invasion of the pleural space, then this is pneumothorax. So, ibig sabihin kasi, kumakain ng space yung collapse na lung ninyo. So, that's pneumothorax. But if it's a collapse of the lungs only or collapse ng lungs na walang invasion of space, then that is atelectasis. Okay? So there are three types, major types of pneumothorax. So we have the simple or spontaneous pneumothorax. Na-discuss na rin naman to. You have traumatic pneumothorax and tension pneumothorax. So yung simple or spontaneous pneumothorax, usually, may dahilan na ito disease process. Okay? So kapag tuloy-tuloy na nagkakaroon ng problema ang lungs mo, like for example, severe tuberculosis, that may lead to spontaneous pneumothorax. Yung traumatic pneumothorax, it happens when there's some trauma or injury. So like for example, vehicle collision, tawag dito, pointed object inserted, sinaksak, for example, pagbagsak, paghampas, so that's traumatic. Tension pneumothorax, nangyayari naman siya madalas kapag nagkaroon ng small opening ang iyong chest. For example, natusok ka ng screwdriver, ang sakit. Okay? And then nahugot yung hinugot agad yung 'di ba sinaksak ka na tapos hinugot pa. Okay? So there's a chance na pumasok ang air through that butas. So that's tension pneumothorax. Okay? Though it's a trauma, it's an injury, pero it's tension kasi nga kita mo na may opening. Okay? Doon sa trauma na walang opening, yun yung tinusok ka pero hindi naman hinugot. That's the reason why kapag kunwari merong saksakan na nangyayari, di ba? Ayaw nilang ipabunot yung kahit anuman because that may lead to further damage or further destroy of a certain organ. Kaya ini-place sila intact. Well, except for the pagka EMS ka or ikaw ay medic, pwede mo hugutin. Pero kung hindi ka medic, stabilize mo lang yung object na nag-cause ng injury. And how? Balutan mo yung site, yung wound site, okay? Para hindi na mag-further na lumalim yung saksak. So that's pneumothorax. So usually, sa pneumothorax ang ginagawa natin is CTT, chest tube, ano nga ito? Ano nga yung CTT? Chest thoracostomy. Basta ginagawa siya thoracentesis. Na ang responsibility niyo doon is to make sure that the bottle is sealed and there is bubbling. So pag may bubbling, ibig sabihin nagkakaroon ng correction of pressure from the lungs and the environment, which is the bottle itself. So kino-correct niyo yon. Pag wala na, ibig sabihin negative pressure na ulit yung lungs. Okay? So the responsibility is to maintain that it's bubbling, okay, or oscillation. Pulmonary embolism, okay, so we all know for a fact the pulmonary embolism, ito yung blockage in yung pulmonary, usual pulmonary arteries that can also lead to blockage of your other parts of the of your lungs, okay? So kapag may pulmonary embolism, this may result to cor pulmonale. Okay? Kasi if you have pulmonary embolism, may blockage sa lungs mo, this may increase your pulmonary pressure or pulmonary hypertension. Okay? So what causes the pulmonary embolism? Maraming dahilan. Okay? So nagkakaroon ng pulmonary embolism kapag nagkaroon ng thrombus outside from your lungs, ang naputol at nag-travel at bumara sa baga. Or sa baga nagkaroon ng massive na blood clotting and then nagkaroon ng pagbabara because of that clot or because of the cystic fibrosis, masyadong thick ang mucosecretion which may lead to pagbabara. So that's pulmonary embolism. Okay? So kapag pulmonary embolism, ang isa sa makikita niyo dito na manifestation is that nakalimutan yung banggitin sa signs and symptoms. Dito sa pulmonary embolism is that you have increased pulmonary hypertension, and therefore you have tachycardia. Why you have tachycardia? Kasi nga barado ang lungs mo, nagpa-pump ang heart mo ng blood towards your lungs. Nagpa-pump ng blood yung heart mo towards your lung, and because there's a blockage, there's a resistance. And when there's a resistance, the heart would try to pump fast and hard. So which would result to your tachycardia. Okay? So that's your pulmonary embolism. Okay? And then next, you have your